Okay, this is a lecture that I gave on radiographically occult lesions, trying to go over some cases when X-ray is insufficient. So we're going to briefly review the concepts of radiographically occult lesions using a case-based approach and going over the various imaging modalities. Approximately 15% of patients who come to the emergency department or urgent care or family medicine anywhere across the primary care spectrum is an orthopedic or musculoskeletal complaint. So it's very common. At least one study suggested that up to 80% of missed diagnosis in the ED is fracture related. I don't think that's really true, but at least one study said that. Let's call it half or even a third. It's still extraordinarily high. And radiographically subtle fractures are easily overlooked. Okay, failure to recognize these is one of the reasons. And if you're suspicious, then you need to think about advanced imaging modalities or alternative imaging modalities. If you miss a fracture, well, okay, you're thinking you didn't have this really bad mid-shaft humerus fracture, it was something subtle, you'll be fine. But the truth is you can have loss of function, disability, and early detection improves outcomes, right? More effective treatment, decreased medical costs, prevents complications, arthritis and AVN being the big ones. And you can really break it down to four types of occult fractures, right? Trauma is most commonly seen in the emergency department, and pediatric physeal fractures. Those are the ones we're going to talk about. Stress fractures are more commonly seen in athletes where their training level exceeds the ability of the bone to heal after exercise, but the underlying bone is normal and healthy. Pathologic fractures are insufficiency fractures resulting from bone with impaired bone integrity, right? Whether that's related to malignancy or chronic steroid use or osteopenia, etc. So starting with x-rays, they're not very sensitive. It depends on what you're x-raying, but the range is 50 to 80%, much lower than you might expect. Okay. There's a lot of subtlety to how the technician acquires those views, and the radiologist can miss things too, right? They're human. And you definitely need to get two views. There's plenty of examples out there where the PA view showed nothing, and then you get a lateral and you see this gnarly fracture. CT is much more sensitive. Again, depends on what you're looking at, but sensitivity approaches 100%, specificity the same. So probably the best pooled imaging modality, I would say, in terms of what's available in the emergency department. You can see 3D reconstructions, which is really helpful both for the diagnosis and for surgical planning if they have a surgical fracture. It can detect subtle fracture lines, depressed articular surfaces, and even evaluate for bone loss. Ultrasound is also very useful, and somebody who knows what they're doing, sensitivity and specificity are very high. This is particularly valuable in pediatrics where you don't want to radiate them. It's billable in the emergency department. But the downside, of course, is you have to know what you're looking at. You have to have experience. It takes time. And maybe perhaps most importantly is the orthopedic surgeons just don't really know how to use ultrasound. MRI is also extraordinarily useful, but generally unavailable in the emergency department. Also looks at soft tissue lesions, which is why it's probably more useful in the outpatient setting, not generally available in the ED. So this is our first case. Okay, this was a 23-year-old male with right wrist pain. He fell off his scooter on the way. These are all real cases, by the way. Fell off his scooter on the way home from the bar. He has scaphoid tenderness and snuff box tenderness, pain with axial loading of the carpal metacarpal joint, does not tolerate a range of motion exam very well, and he's neurovascularly intact. This is his initial x-ray. PA view of his wrist. It is normal. I won't read the whole thing with you, but essentially it's normal. You decide you want further imaging because of how uncomfortable the patient is. You ultrasound his scaphoid and you find these obvious cortical breaks here. Okay, these are not subtle, but you have to take the time to sit down and find the scaphoid with the ultrasound. And if you're not sure what you're looking at, you can always compare it to the unaffected wrist. That's probably the smartest play there. This is his CT, which you also decided to get, and you can see a waist fracture here, which is essentially non-displaced. Okay. In the outpatient setting, he got an MRI, which shows significant bone edema. This is a different patient, not quite exactly the same fracture pattern. Either way, in the emergency department, you place him in a thumb spica brace. And if you don't have thumb spica brace, then you can always use a thumb spica splint. But for what it's worth, braces are generally better tolerated. A second patient, this is a child, right? You can tell because the physes are open on the x-ray. This 7-year-old presents with left ankle pain. He fell off the monkey bars and landed awkwardly. He's screaming, which makes examining him very challenging. Mom's trying to console him. But he's clearly swollen and tender on the lateral malleolus, and otherwise you think he has a good neurovascular exam. You ultrasound this young fella. You start with his right leg, which you see here, and you see a normal lateral malleolus here, right? Here's the physis. Here's the metaphysis, the epiphysis. There's no fluid collection along the soft tissue here. Then you come back to the fractured side and you look at the same thing. You see the metaphysis, the epiphysis. You see a cortical irregularity here, which you suspect is a fracture. You might call this a Salter-Harris 2 or Salter-Harris 1, depending on a few variables. But more importantly, perhaps you see a fluid collection here, suggesting acute trauma, okay? This kid has an injury, and you're going to call it a fracture because of how tender he is right along this ridge, okay? You place this 7-year-old in a walking boot, and they have a good outcome. If they aren't trustworthy, you may have to put them in a splint or a cast. Case 3 is also, this is a real case of mine. 46-year-old male surveyor presents with right knee pain. He stepped in a pothole out in a field while he was surveying some land, had immediate onset of pain, felt a pop, on exam, moderate joint effusion, tender along the medial joint line and medial tibia, does not tolerate a structural exam due to his degree of discomfort, but is distally neurovascularly intact. On his lateral x-ray, you see a large joint effusion, so this is a good teaching point, is you can see effusions on the knee x-ray. It's not necessarily a reliable exam finding, but if the effusion is present, then they probably have one clinically. But the absence of x-ray findings does not exclude an effusion. On ultrasound, a much better modality, you clearly see a large hypoechoic fluid collection. And then on the right here, this is the superior patellar pole and the quad tendon here coming across. So this is all fluid in the suprapatellar recess, okay? Presumably blood in the setting of trauma. You get a CT scan and you see a depressed medial tibial plateau fracture here, right? There's a big cortical depression here. You can see this lateral component is completely sheared off, not always apparent on x-ray. And you place this patient in a posterior long leg splint with crutches after talking to orthopedic consultants for outpatient elective surgical repair. This patient was a middle-aged 25-year-old grad student. He fell off his motorcycle when he was trying to pull out of his parking lot, a very low speed mechanism. He got his arm down. He presents to clinic with his elbow held in about 9 degrees of flexion, with basically unable to flex and extend due to pain. In this clinic, we did not have imaging, but I was highly suspicious. He went to the ED, got x-rays. Here you can see as a posterior fat pad sign. Is an anterior fat pad sign, so sometimes called a Sale sign, but the posterior one is always pathologic. That x-ray was read as a posterior fat pad sign, but no obvious fracture, okay? You get an ultrasound. You put the ultrasound in the back of the elbow, okay? You can see the triceps tendon and long axis. Here's that same fat pad you see on the x-ray, but you see it much better sonographically, right? And then you see the joint effusion, right? So here's this hypoechoic fluid collection, and this is on the posterior elbow. Very easy to find once you know where to look. And then we got a CT of this kid's elbow in the emergency department, and you can see his occult radial head fracture right there. And then the last case is another ankle pain. This is a 54-year-old female with ankle pain after a motor vehicle crash. She had injuries or minor injuries in other places as well. She had a pretty normal ED workup, kind of underwhelming exam. And as my resident was getting ready to discharge her, she said, "Oh, her pain in her ankle is much worse. Can we give her something more for pain?" And I thought, well, that's kind of weird. So I brought up her ankle x-ray again. This is her ankle x-ray. There's really no soft tissue swelling. There's no obvious fractures or injuries here. You can stare at it all day, but I couldn't find anything, and neither did the radiologist. So we decided to go straight to ultrasound, and you put the ultrasound probe on the front of her ankle. Okay, this is the distal tibia. This is the calcaneus, right? So this is the, sorry, this is not the, this is the talus. This is the tibio-talar joint on the front, and you can see a joint effusion here, right? This is hypoechoic fluid. In the setting of trauma, that's blood until proven otherwise. Doesn't tell us that there's a fracture, but it says something's going on in the ankle. We then get a CT, and you see a nice occult talus fracture, really without any displacement here, which you did not see on the x-ray. So in summary, x-ray sensitivity is pretty low when you're looking for fractures, okay? You have to consider the mechanism of injury, the clinical context, and the physical exam, which, by the way, the radiologist does not have all that information, so it's very important to look at your own x-rays. If there are point tenderness on bony structure that you're concerned about, or they have pain out of proportion to exam, you should be clued in that something else is going on. A joint effusion on x-ray and ultrasound is a big clue, but of course does not tell you that there's a fracture. Ultrasound and CT have a large role in ensuring the correct diagnosis and treatment.